All right, welcome back, everybody. If we can have folks please join us back at the table, we'll be starting. Well, thank you all for being with us. It's been such an incredibly eventful day, and now we're transitioning over to our public comment section of the day. We are very lucky to have a lot of public comments to have been sent in. Everything that's been sent to the PACCARB at HHS.gov mailbox has been submitted to the council members and is available on the SharePoint site. We also have printed comments available at the registration desk if you'd like to pick up a stack just to see. The companies that have sent in their comments are from the Natural Resources Defense Council, the AMR Action Fund, the Food Animal Concerns Trust, Keep Antibiotics Working, OpGen, and Health Watch USA. And as I indicated, all of these written comments can be taken. We have printouts at the front desk at the registration if you'd like to see what they've said and indicated in their letters. I'm going to turn it over to Dr. Blazer shortly for our verbal comment. For those of you that have joined us live here, thank you so much for making it out and joining our council members. Please know that we have a full lineup of presenters, so please try to limit your comments to 2 minutes. And I'll turn it over to Dr. Blazer.
Thank you, Joanna. Now we come to the oral public comments. As Dr. Musmar has said, we will all the speakers are limited to 2 minutes. I'll gavel them down after 2 minutes. And so our first speaker is Stephen Roach from the Food and Animals Concerns Trust. Mr. Roach.
Hello and thank you. So I'm Steve Roach. I'm the Safe and Healthy Food Program Director.
Okay.
Okay, thank you. I'm Steve Roach, Safe and Healthy Food Program Director at Food Animal Concerns Trust. FACT has been disappointed that much of the discussion around pandemic preparedness has ignored the role of animals, despite most of these diseases being zoonotic. So we appreciate PACCARB's use of a One Health approach to address pandemic preparedness. At the same time, FACT is concerned that today's meeting is too focused on responding to a pandemic and not focused on what we can do to prevent future pandemics. Prevention requires that much more effort on monitoring for pandemic potential pathogens, including antimicrobial resistant pathogens on farms and feedlots. We call on PACCARB to support the development of national monitoring program for pandemic potential organisms that includes both bacterial and viral threats, with the goal of preventing spillover from animals to people. In terms of these, we support the non-voluntary monitoring programs, or what Dr. Blazer called non-cooperative monitoring programs. For antibiotic resistance, we also need more focus on prevention. We need to do much more to reduce the overuse of antibiotics that is driving resistance. There's a lot of talk about antimicrobial stewardship as a tool to combat antibiotic resistance, but stewardship will not reduce resistance if it does not lead to reduced use. It is not clear whether all federal agencies support reducing antibiotic use as a tool to combat antibiotic resistance. Both FDA and USDA staff have opposed language supporting reductions in use in international settings. I also once received an email from USDA staff telling other staff that the US government policy was to not refer to reducing use in agriculture. It is also not clear that PACCARB itself support reducing use. FACT calls on PACCARB to be clear about the need to reduce antimicrobial use in agriculture, antifungals in plant production, and antibiotics in food animals, to ask federal agencies to support use reduction, and to call for national targets for reductions in use of antimicrobials in agricultural settings. Thank you.
Thank you, Mr. Roach. I now call on David Walinga from the Natural Resource Defense Council. Mr. Walinga.
Thank you, Mr. Chairman and members of the PACCARB. I hope that volume level's good. So interesting observation from that last session. I think that in the US, we haven't seen much, there hasn't been much recognized public value for several decades around collecting data around antibiotic use. And as one result, when the marketplace recognized a private value to it, we had companies buy data, or at least use sales from drug companies and then reselling it to other drug companies and eventually back to the government agencies themselves. So obviously things have changed, and we now realize that there's enormous public value to tracking and reporting antibiotic use. But as our discussion reflected, there are a lot of complications, and so we still don't do it, at least not very robustly. So NRDC's written comments reflect that observation. We make some recommendations intended to align the incentives to collect antibiotic use data with the public health benefits from collecting that use data. CDC's leadership has set a good example in terms of a national goal in the National Action Plan to curb the overuse in outpatient medicine of antibiotics by 50%. And if I'm reading the website correctly, CDC subsequently acknowledged that they needed to do a better job to actually collect use data in those settings and identify ways to address overuse. But we're kind of still at an awkward point in terms of the majority of medically important antibiotics that are sold. In fact, about 2/3, twice as many are sold for use in food animal production as for human medicine, but we don't track that use at all. So our first recommendation to Secretary Becerra from the PACCARB would be to set a 50% national use reduction goal for the food animal sector. And then longer term, hopefully that would spur more collection of use data at the farm level to measure progress towards meeting that goal, just like it has in the CDC.
Mr. Wawinga, your time is up.
Oh, okay. Thank you.
Thank you. I now call on Amanda Jezik from Infectious Disease Society of America.
I'm a lot shorter than the last couple speakers. Thank you for the opportunity to provide comments. As you consider the many important components of infrastructure for pandemic preparedness and AMR, including surveillance systems, vaccines, diagnostics, therapeutics, I urge you to remember that fundamentally, our success in preparing for pandemics and addressing AMR relies upon people. The life-saving potential of new tests and therapeutics can only be realized if we have an expert workforce able to optimally use these tools in all communities. And we do not have the workforce we need. ID physicians, clinical microbiologists, infection preventionists, and ID pharmacists are all critical to pandemic preparedness and AMR, and they're all in short supply. Nearly 80% of counties in the United States do not have a single ID physician. Year after year, only about 70% of ID physician training programs are able to fill their slots. Patients with serious infections, including resistant infections, have better outcomes, shorter hospital stays, and lower healthcare costs when they're treated by an ID physician. And during the COVID-19 pandemic, some studies have shown that hospitals without ID physicians had far greater increases in HAIs. So why aren't more physicians pursuing ID? It's among the lowest paid subspecialties in medicine. The codes that ID physicians primarily bill, inpatient evaluation and management codes, are severely undervalued. This is a familiar problem in the AMR community. As we've long discussed, we don't sufficiently value antibiotics, so as a result, the antibiotic pipeline is in trouble. The same is true for our pipeline of ID experts. IDSA encourages the PACCARB to work with CMS to improve reimbursement for ID physicians, to strengthen the workforce necessary for pandemic preparedness and AMR, and to ensure patients with or at risk of serious infections can access an ID physician. We need targeted, sustainable initiatives to invest in the multidisciplinary ID workforce, and we urge PACCARB to please prioritize this important issue. Thank you.
Thank you. I'd like to call now on Bronwyn Morgan from the Commonwealth Scientific and Industrial Research Organization of the Australian Government, or CSIRO. Ms. Morgan.
Opportunity to address you today. So Australia's National Science Agency is looking to stand up a mission on antimicrobial resistance. And we'll be taking a One Health approach, specifically focusing across 3 work packages: prevention, management, and response, both in the sense of containment and treatment. Now, we of course recognize that the interventions and solutions are many and varied for antimicrobial resistance, and that we need to prioritize, particularly because we are a small country. And we need to ensure that we leverage initiatives in other countries. But while we have prevention at the heart of what we do, and indeed the Minimising Antimicrobial Resistance mission will be weighted towards prevention, we know we need to have a robust framework for determining and evaluating what preventive measures will have the greatest impact on reducing the evolution and transmission of antimicrobial resistance. So what we would love to see from PACCARB is to know how members of the panel and the committee are deciding what to do now versus what to do next. And which evaluation parameters and frameworks would you use to prioritize interventions, be those interventions, products, processes, or policies? Thank you.
Thank you. Our final commenter today is Mr. Henry Skinner from the AMR Action Fund. Mr. Skinner.
Thank you for the chance to speak. I think we already know with this pandemic, as well as the next one, that AMR is an issue. We've seen a rise in AMR of 15%, increased use of antibiotics treating COVID patients. We certainly expect to see that next time as well with these co-infections. We need holistic preparedness. We need improved surveillance, improved diagnostics, improved stewardship, and we absolutely need new antibiotics. We need to be able to treat the resistance mechanisms that are emerging around the world and a growing crisis everywhere. The problem is, of course, as you know, the pipeline is thin. It's also fragile. The absence of capital to invest in this field over the last 20 years due to a number of bankruptcies, market failures, and frankly, a market that doesn't reward new antibiotic development. You know, we need to move to a value-based reward and away from a volume-based reward. If we don't do this with pull incentives, of which the federal government has a critical role, the human capital that we have is aging and fleeing this field. We will not have the scientists, the entrepreneurs, and the developers to move products forward, and we certainly won't have the capital to bring things to market or approval to have them available during the next pandemic. Thank you.
Thank you. And that closes our public comment session. There'll be another opportunity tomorrow as well. Now I'd like to turn over the podium to Dr. Apley to wrap up the day's events with a round robin.
Thank you, Dr. Blazer. One of the things I've noticed in 7 years now on the council as one of the founding members is a wonderfully diverse range of professional and personal experiences and expertise. Continue to be amazed at what we all have to contribute. And so for that reason, the round robin isn't optional, okay? If we go a little long, I'll take the hit with Joanna, all right? So don't worry. I warned Dr. Plummer he's going to start, so we're going to go around the table this way and end up with Dr. Blazer and then myself. And if you have some type of reflection from today, if you don't, feel free to pass it on. But I, and I'm sure the rest of the council, would be happy to hear if you have some type of reflection or a take-home on today's proceedings to wrap things up. So, Dr. Plummer.
Thanks. I want to thank the speakers, the panelists, for great presentations today and really good discussion. Luckily, I get to go first, so I get to say the things that I think, and then y'all can all say same thing or whatever. But oh, just one. Oh, okay. So one good one is I think we talked a lot about collaboration and the impact of that collaboration on building trust. And as it relates to capacity building and scaling up, trust building is hard to scale up rapidly if it hasn't been established before the scale up's necessary. So I think that's a take home that we need to think about.
I didn't know I'd have to do this, but I have a lot of scratch notes. So I think, there's a lot to reflect on for today, but one of the things that I was really focusing on, I think throughout all of the modules, was really thinking about attention, and that collective attention is a scarce resource and can only focus on a certain number of threats at once. And so how do we think about supporting collective attention on our scenario in ways that are going to help mobilize people working together? Because I think when people are split in many different directions, we threaten our ability to respond. So I want to think about attention and collective attention, and particularly our task, which is what kind of federal or policy solutions could we put into place to help encourage that? So thank you.
I don't have anything as pithy as that, except I'm continuing to listen for, because I'm in education, so that's what I'm always thinking about, is how do I train the next whatever, whether it's veterinarians or others that I'm not as familiar with the pathway, but that's what I'm always thinking about. And so that's why I asked the question about what's the role of this group or this report as it relates to application of diagnostics and appropriate use of diagnostic tests and decision making. And so I'm continuing to listen for that in this conversation, is how do we make decisions about supporting whatever efforts we think should be federally supported, but then how do we educate the users of that information?
I have less than you. No, I full day packed with all kinds of information. I mean, for me, being the only patient advocate here, I can tell you that I am truly humble and honored to be among all of you. The fact that I can once in a while push that button and speak up, it's mind-boggling to me. So I thank you very much, and thank a wonderful panel, and the speakers were just tremendous. The one thing that I may suggest is that more brainstorming like we did earlier. I think we would come up with some great innovative ideas, and I think we should move forward towards that a little bit more. So.
I also want to thank all the speakers. I was particularly impressed with all the progress compared to some earlier PACCARB presentations on our capacity to track and monitor and develop, and I'm sure we'll learn more tomorrow. What I'm particularly struck with in the mindset of One Health is I think we have many similarities between the human and animal health response to AMR, and I think it's really time for us to push the envelope on this and find ways to truly do it together and not just in parallel. I was impressed by some of the animal monitoring that's out there, and I think we could model that and combine efforts, not just follow each other side by side as we go forward. Thank you.
Hi, everyone. Emily Wheeler from the Biotechnology Innovation Organization. I think as I reflect on the conversations today, I think about really the backdrop for today's conversation and this connection that we're speaking about today between AMR and pandemic preparedness. I think a year ago or a year and a half ago, 2 years ago, that connection would not have been so concrete and described as it was today or understood by the general public. And I think we've long been describing antimicrobials really as a pillar of all medicine, but we really saw with COVID over the last several years of the role that effective antimicrobials, that work, play in these crisis situations. And I think as we think about the work that needs to be done to ensure we have a sustainable pipeline of products to provide patients and physicians with the therapeutics that they really need. Having this concrete connection, all the work that came out of COVID to make those concrete ties is really, really helpful. And hearing everyone expand upon that today really is what I'm leaving with as a main important takeaway.
Hello, Lisa Maragakis here representing the Healthcare Infection Control Practices Advisory Committee. I just wanted to share two reflections. One is others have said during the meeting multiple times about our workforce issues, and I think that must be emphasized. I know that almost every segment of society has really, suffered and reeled in different ways during the pandemic, but none as much, I believe, as healthcare, and in particular those who are on the front lines of infection prevention in our labs and on the front lines of healthcare facilities and public health worldwide, really. So I don't know what we can do about that, but I just think staying attuned to the well-being of those who are already in the field, and then doing what we can to try to attract others and retain those that we do have. And then the second one was something that Ramanand said earlier. I really liked your comment about zooming out and keeping the bigger picture in mind so that we really are very intentional about what we're trying to accomplish when we think about something about surveillance or new diagnostic tests in particular, but really any of our activities, that we have to keep it connected to the overall purpose. And I think that's been one of the real challenges of the pandemic response, of making policies and responding, is always trying to keep that bigger picture in mind and avoid the unintended consequences. Thank you.
Mark Albrecht, coming to you from BARDA. I think I reflect on Don's comments at the very beginning of today, really noting the fact that antibiotics are critical towards any public health emergency response. It's not just responding to a chemical event or a biological event. You must be able to treat multi-drug resistant infections in the hospital and those that just generally come in from the community. And I think that today's session has really highlighted that, as well as tomorrow's session. We'll get to that further. But what I've also heard is the fact that diagnostics really have come a long ways. And I think through the COVID events that we've seen over the last couple of years, we've really identified what has worked and what is working, as well as other gaps that really we need to start focusing in on. So really appreciate the fact that the light has been turned on those gaps, so we now have a little bit more of a heading, an idea of where to go in the future.
Jasmine Dunza from CMS. I will echo everybody's comments, and I'll make another one that no matter how far we go with diagnostics and therapeutics, it has to be accompanied by appropriate messaging and communication, so that it can be taken up by the general public. And unless the message is there, no wonder drug is wonderful unless it is taken up by the consumers.
Hi, I'm Paige Waterman from the Department of Defense. And I have two thoughts. The first comes from sort of my background, which was largely in AMR surveillance. And I guess I would echo what a couple of folks said, I think Tom and Elizabeth, and to really access the data that we have, whether it's from hospitals, procurement systems, pharmacies, really insurance providers who know what prescriptions are being written. I think there is a treasure trove of information that isn't always available to the federal government, certainly. And then secondly, how do we, and I speak from human health, I would apply that to animal health as well. But my second point is, how do we use and develop data systems that actually allow us to see information at a real time more efficiently without blaming or shaming, but at the same time respect privacy and security for folks? Thank you.
Bill Flynn, FDA. I guess we talked today a lot about the gaps that exist in surveillance as well as diagnostics. I guess a couple of things that struck me was sort of one of the important values of this group is having these discussions with both the human medical and veterinary sectors, sort of putting these ideas on the table, comparing notes. There's the opportunity for sort of leveraging models, things that might work on one side that could be applied to the other. So, I see that as a real important value of this group and opportunities to see how we can sort of work collectively to sort of fill those gaps, whether in the veterinary sector or the human healthcare sector. And then the other thing that struck me today too was just the emphasis on, we talked a lot about the need for data and diagnostics in terms of informing what we're doing in our surveillance programs, but also the importance of sort of having clarity of understanding of sort of what we're going to do with that information and how that's going to affect sort of how we're using antibiotics and how that information is going to be communicated. Thank you.
Melissa Miller, AHRQ. I think the theme that I heard over and over again is that the innovations and the best response that we had during this pandemic were based on structures and processes that were in place prior to the pandemic. So to borrow a metaphor from another field, if pandemic is wartime and in between pandemic is peacetime, I think our response to the next pandemic will depend on ongoing investments in peacetime, in data, public health, research, and workforce. Thanks.
Barbara Fernandez, National Biodefense. I agree with everything which was said, and instead of repeating those, I was thinking, what's different now? In 1995 or so, we published the OTA on the problem of AMR and how it's going to take over things. And that was 1995 with people who are no longer around, like people, Bob Mollering and stuff, were authors. And I said, what's different now? It's the pandemic. So now everyone, the whole world, every single person is aware that a bacterium or virus can change the entire world structure, the world economy. When it hits the pocketbook of the world, that's when people are paying attention. So the time is now to act and to show why we have to be different, how our infrastructure has to be different. And as Melissa just said, is to set it up now in peacetime so that it does not happen again in this way to affect the economy. That will ring a note to say people will make an investment so this way the economy is supported.
I guess we're down here. Great. Chris Options from BARDA. Yeah, I think the one thing I was struck with was probably one of the best comments today from Arjun, which is the answer to every question is money. So it really reflects what Michael said also, that you can't depend on having funding at the time of an outbreak of an event. You have to have that up front. And it really is true. We need to be able to have resources, funding to be able to tap in right away. We need a fund that allows us to be able to activate it and start supporting, kind of a surge response or a pandemic response right away. The other thing is that I think is absolutely critical, and I think this was touched on by a number of people, is, having the appropriate staffing, having the appropriate personnel, having the appropriate technical personnel, the appropriate clinicians, technicians, whoever it might be, to be able to respond to an event. And that is not something that you can just staff up overnight. It takes training. It takes hiring. It takes ensuring that you identify the right people to do the job. And one thing that I was thinking about, way to address it, is have a mechanism like we do in the government right now, where we have the NDMS, or the National Disaster Medical System, that allows us to be able to bring in people from the public sector who are trained to be able to respond to a disaster. If we could have a similar system to respond to a public health emergency like a pandemic, to be able to surge technicians, people that can do diagnostic tests, people that can, serve in these other functions that would allow us to be able to respond to an event, I think would absolutely be critical in such a scenario. But thank you.
Hi, Natalie LaHood, Office of Global Affairs. I guess it would be important for me to mention that we shouldn't lose sight of, or a key reflection I've had thinking about the session today is that we shouldn't lose sight of the international perspective. When we think about, and I'm reflecting on the earlier comment of collective action or coordinated action, I mean, that goes beyond our domestic response, whether it goes from, developing medical countermeasures with therapeutics, diagnostics, or we're talking about surveillance. Those actions and policies that we put in place domestically have an international impact. And if we can better align that kind of coordinated action or collective action, we're going to put ourselves in a much better place and be better informed to be able to respond to a future pandemic. Thanks.
Hello, this is Kyungmoon from NIAID, and one thing, the major lesson that I learned from is that the major gaps in the diagnostic, not only for the rapid diagnostic, but also for the fungal diagnostic, which is a major gap. And from there, the NIH has been supported the various, research and development for the better diagnostic, but one thing, major thing that I learned is that we continue to support the new diagnostic for, having a faster, closer to the patient and more accurate diagnostic. And then for that, we need to have not only the translational or clinical study. Another committee member mentioned that we need to have also basic research so that we can find the proper target. So that's one thing that I learned. And then the last thing I learned is that we have to support the research for the develop the new technology, but how to keep the pipeline. I think that is a major, question that we have to answer. Thank you.
Michael Craig, CDC. I would just reflect on very positive feedback at some of the efforts that CDC have had to develop new surveillance methodologies and platforms, whether it's the AR Lab Network or the National Healthcare Safety Network or the National Wastewater Surveillance System. Also heard a lot of high expectations of things that you would also like to see us do. I think that part of the reflection on me is just hoping that we have the resources to not only continue the things that we have started that folks like, but also to be able to meet those expectations of what folks would like to see.
Chelsea Shively, USDA APHIS. I'm pleased that you were all able to hear from several of my colleagues today about the work that we're doing within APHIS to address antimicrobial resistance in animals. I would like to see us continue to expand the scope beyond our traditional livestock species and consider companion animals and wildlife and other animals and how they interact with humans. I was reassured to hear a lot of the challenges that we face are common amongst all of us, thinking about data protections and privacy and confidentiality. Those are not unique concerns to USDA, so I think we need to work together to address that. And I look forward to applying all of these lessons learned across the One Health approach to other aspects. So looking to the environment and how we can take the lessons we've learned today and tomorrow and look to other areas. Thank you.
Jason Newland, Pediatric Infectious Disease Society. I really appreciate the opportunity of being here with everybody. It's amazing. I've learned a ton, obviously, always sitting next to our colleagues from the animal industry, as we don't talk enough about that. I say a lot of reflections. The workforce issue is scary, knowing about children's hospitals not having 25 or 30 beds going into a early RSV season and these other things. I think I appreciate all my colleagues and everyone that's brought that up. Obviously, from a pediatric perspective, while the current, as we get through the COVID-19 pandemic, we haven't felt it up front so much, but the collateral damage of the pandemic always makes me just cringe when we have to talk about a new pandemic. And I think the AMR pandemic for pediatrics will be somewhat even more difficult in the sense of new drugs and new therapeutics or new vaccines are always slow. And the diagnostics also could be slow. And so I think our colleagues in the pediatric space are always thinking, how do we maybe speed that up as we move through these sorts of scenarios? But thank you again for this wonderful opportunity.
Carla Houston, representing the American Association of Extension Veterinarians. And I've ditto what everyone has said so far. We've heard a lot from industry, academia, government. And the one reflection that I would have in listening to all this, and just as been said, not to forget the global perspective, I want to encourage not forgetting the ground level. We have a lot of practicing veterinarians, our prescribing docs, our parents, our farmers, our ranchers, our pet owners. So I'd like to make sure as we continue this collaboration and integration of ideas and policies that we don't forget about the outreach and education that has to go along with that. Thank you.
Tim Jinks, Welcome Trust. So when I think about the U.S. National Action Plan, it's really been reassuring to see that there's been improved coordination at the federal level. So really good and strong signs of success in that territory, and it'd be great to see continued progress at the level of U.S. coordination. There's certainly gaps, though, as relates to federal action that support effective implementation of interventions, and particularly sustained investments to keep those interventions in place. Something that we need to consider, and I think that this group needs to put forward more ideas on, is prioritization of the very large to-do list. I do want to reiterate, though, the significant gaps related to human capital and skills capacities. This is something that is a recurrent theme, and one that clearly we would be remiss if we did not highlight as an important issue to be addressed. Thank you.
This is Payal Patel, one of the voting members. One thing that struck me during the diagnostic session is I give a talk, and in that talk I go through a number of studies that show that when you buy a fancy new diagnostic and you don't have a stewardship team that's effective, nothing happens. There is no effect at your hospital. So I think at the end of the day, we really need to think again about how we have actually, because of Dr. Srinivasan's efforts and the CDC, we have a lot of effective stewardship teams in the US. And how do we take that internationally? And I think that could make a huge difference in and outside of the pandemic. So that's kind of something I was thinking today.
Hi, Stephanie Black, one of the voting members, and happy to be a part of this discussion. I have two things I just wanted to mention. One was talking about sustained and flexible funding. The topic many have mentioned. I'm very concerned about the workforce, particularly with public health, just the support that we are giving to other less well-resourced facilities, like nursing homes, but like under-resourced acute care as well. So want to keep equity front and center. And then also, I just was really impressed hearing about the National Animal Health Lab Network and relating that to how beneficial ARLN has been for public health, and just hoping that, like I think Elizabeth Dodds-Ashley, you were talking about working in concert rather than in parallel, and hoping we can do that more. Thanks.
Dave White, one of the voting members as well. I want to thank Dr. Apley for doing the round robin. I think this is a great idea. A couple observations stem from my 17 years in the federal government, and then leaving that to become an academic for 6 years. Is they used to call us silos of excellence. We weren't talking to each other. I see that changing over time, and if there's any silver lining in the pandemic, it was that it fostered a greater degree of communication and collaboration across the federal government, as well as industry and universities. But on that, I think we're also drowning in data. There is so much data out there. We don't have the data architects to pull it all together. And I think maybe we need to bring in data scientists into this conversation at some point to help us kind of mine the data for informed decision making, because there's just so much out there. And I don't think, as a microbiologist, I can't figure it out. I need someone that understands data and can pull it all together. And lastly, I still think, from my perch in academia, we need to do a better job of science communication to the lay people. They're just not getting it. we can talk to each other at a professional meeting, no problem. But when we go talk to, say, a state legislator, we use too many acronyms. We don't explain the situations the correct way. I think we need to do a better job at science communication for both our faculty, our scientists, and for our students coming into the professions. Thanks.
Elaine Larson, voting member. Two related observations, sort of riffing on what's been already said. First of all, having been on PACCARB now for a few years, I sense a real feeling of renewal, but more than that, that we need to focus not on the past and the present, but on what is sustainable and what is actionable for the future. And to me, I have to think about that consciously. Every time we talk about an issue, every time we talk about recommendations, keeping in mind that it's got to be actionable and it's got to be sustainable. Sort of a related thing, we are actually sort of what David said. We have a lot of data. We understand much better now what the data are and sort of the current and the past state of what's going on. But we want no more rehashing of the same old solutions that haven't been working. And Ms. Ramanan brought this up before. Even though we're talking about things that are bureaucratic, difficult to deal with, we need to be creative, we need to be innovative, we need to get outside the thinking of the boxes that we've had with possible solutions.
So it's hard to say anything particularly profound after 25 people have spoken. I'm just thinking back. When we had this PCAST working group, at least maybe a couple of people here were on that, which started the whole CARB plan and everything from there. And I remember that the instruction that we had from the co-chairs at that point were Eric Lander was one of the co-chairs, and he basically said, well, the president wants a plan. He wants it to be ambitious. He wants it to be quick, and he doesn't care if it's perfect. And I think that's what we need now. We need to do something that's completely ambitious. Of course, it has to be quick, which I guess Joni and I are a little more, stressed out about because we've got to make sure it gets to the finish line, else there would be hell to pay. But I think we've got to be ambitious, and I think it doesn't have to be perfect, but it has to be far more ambitious than where we've been so far. If we're just saying, I think we should go back to the CARB plan, which was actually an excellent plan. If we're only saying things that were said back in 2015, we didn't need all these years of thinking to get to where we are. And I think if there are things that need to get called out now, whether it's Michael's concerns about CDC losing funding for wastewater, in a few months, or there not being, an equivalent animal surveillance infrastructure the way that we have for humans, or whatever it might be. It doesn't matter what it costs. We've gone from 2014, $10 million spent on antimicrobial resistance to probably $1.5 billion spent today. If we ask for another $500 million, that's not going to break anyone's bank. I think we can do that. But I think we need to be ambitious here, and I hope we will be. Thank you.
That was pretty profound. This is Joni Sheftel. I represent the American Veterinary Medical Association here. One thing that's come out today is that we can't really predict the future. We keep trying, and then we fail at that because something surprises us, comes out of nature and completely surprises us. Another thing is when you're looking at that intersection of human health and animal health, that's another place that can't be predicted. Think about SARS-CoV-2 in deer. There's no way anyone would have predicted that it's found in deer all over the United States. Think about monkeypox in people's dogs. We just can't predict what's coming next, but I do think we should expand our focus off of it to include the whole human-animal interface and not such a razor focus on food animals, because there are lots of animals out there that we intersect with And in fact, in companion animals, there's a lot of antimicrobial use, and there's a lot of resistance problems that are a problem out there too. So let's just keep our minds open and try not to depend so much on the past for what we think is going to happen in the future.
Wow, I'm lucky I get to go last after all these great comments from everybody. Oh, I'm sorry, Marty, excuse me. No, I mean, when I think about it, we look at the lessons from past chaos, right? So we had H1N1, we had anthrax, we had Ebola, we had Zika, and now COVID. And they've all been terrific impetuses for us to really develop these terrific programs that we have now. So I've been on PACCARB for 3 years, and I can tell you, when I listen today to the surveillance systems that are now in between animal and human health, this is light years difference than what we had 3 years ago when I first joined the committee. So, I mean, it's been absolutely terrific. But what I'm concerned about is, and we talked about it, is keep moving forward. Where is the sustainability? I want to be proactive, not reactive, right? We don't want to wait for the next funding because we have another outbreak of some bizarre disease, and that's how we're going to get funded for the next steps. So I really think we have to think about how we can convince the right people that it has to be sustainable now so that we're ready to deal with the situation. What we need for them, we need to develop now. We can't wait until we're in the middle of the next pandemic. And I think this has to be very proactive across and between both the human and the animal sectors. So hopefully that could be one of the outcomes from our working group. So thank you.
Thank you, everyone. Marty Blazer. I want to follow up on several of the comments that have been made and amplify them, in part because of what we've learned from COVID. We have vaccines that have been given to billions with unbelievable safety and efficacy, yet so many people don't understand and don't believe the scientific basis of these. And as a result, they're not taking advantage of them and even obstructing them. So learning from that, I would advocate that every activity that's part of the AMR solutions going forward should have a communication plan. And that addresses how do we communicate to the public and to the health professions. And I suggest the following 5 points in each plan. First, actually even before the 5 points, to use simple language. And the 5 points are to provide the rationale for what is being advocated, to discuss its feasibility, to consider the cost of not doing it, to present the need to modify as events and knowledge change, and to emphasize the central importance of the public trust. We can develop awesome science, but if the public is not on board, we lose a lot of value.
Well, that was awesome. I know you guys thought that was pretty awesome. And I wrote it all down. I wish I had a mic to drop, do a pin. So it's great. And those of you who don't punch that mic button as much, that's how it's done. And we love to hear your voice. And the thing about this council that I noticed from today and past days is I don't think we rough it up enough. We can disagree without being disagreeable. So from your experience and your thoughts, if there's something you go, I don't know if I quite agree with that, punch the button, get in there. We're all friends here and we love to hear from you. And again, I'll just emphasize the value of your individual experience, your expertise, and bringing it to the council. So jump in there, give it to us. And we have the work session. We have our working groups coming up. We've got tomorrow. And tonight, I think the big message I took home from this, tonight, think about do, right? Think about what we do, what we advise the government to do. A lot of great ideas here, but I think the theme for tomorrow and as we move forward is do in the future. So with that, let the record show I'm turning it back to Dr. Musmar 2 minutes ahead. Thank you very much.
Thank you, Dr. Apley, and thank all of you for your tremendous feedback and active engagement. This is the sort of conversation that advisory committees are meant to have, and you fulfilled that, so we appreciate all of your insight and your input. Believe me, we've got a lot of material to work with, and we need to get some more material tomorrow as this conversation continues. A lot of the council members indicated their service on the council, and I just wanted to let folks know that are watching us virtually and also here. We do have vacancies coming up next year. The application page is open, so if you'd like to be part of this table and join in, some pretty big shoes to fill. Please be sure to apply online and for consideration on the council for both liaison and voting member positions. And I think this report's going to be extra special because I think as your last reports, you're probably going to ruffle a lot of feathers, and I hope you do before a lot of you rotate off come next year. Thank you all so much for joining us today. Thanks to everybody in virtual land, and we will see you tomorrow early on time at 9 o'clock. Have a great one.
Produced by the U.S. Department of Health and Human Services.